Good morning. I'm going to first talk about the evaluation and diagnosis of pancreatic masses. So I know it's early in the morning, but we'll start off with a little quiz. Here we see 4 CT scans, and these are not uncommon to a lot of patients that we'll see coming in the hospital. And when we see something like this, the question is, which of these patients have pancreatic adenocarcinoma? Which of these patients need surgical evaluation, oncological evaluation, etc. And in actuality, all of these lesions are not pancreatic cancer. These are mass lesions which can be sometimes benign, sometimes malignant, sometimes need resection, sometimes need radiation, steroids, other treatment modalities. But in reality, what we're talking about is pancreatic cancer. It's the 10th most common malignancy in the United States, 4th leading cause of cancer-related deaths. And although the vast majority of malignant pancreatic neoplasms are ductal adenocarcinoma, there exist many different tumors that can present in the pancreas, as well as functional, non-functional endocrine neoplasms, numerous benign etiologies of pancreatic masses as well. 2% of these masses are metastatic to the pancreas from somewhere else. Overall, we've seen the incidence of masses within the pancreas remain steady, but neuroendocrine tumors and some of the non-adenocarcinoma type lesions have doubled in incidence in the last 16 years. This may have something to do with the greater utilization of CT scans, MRIs, for other indications. We all know that pancreatic adenocarcinoma carries a very poor 5-year survival, somewhere around 5%. And traditionally, it's been felt that about 15 to 20% of patients have resectable cancer at the time of diagnosis, which translates to a 35% 5-year survival. Thus, it's imperative that this is detected early. So when we see someone who has a known, visualized, or suspected pancreatic mass, we should assume that all these lesions are adenocarcinoma until proven otherwise. So how do we best evaluate these lesions when they're seen? And it really comes down to a story of then and now. 80 years ago, this woman was probably your only choice for non-operative evaluation of a pancreatic tumor. This is Sister Mary Joseph Dempsey, who described a periumbilical node in the early 1900s, which was later phrased the Sister Mary Joseph node. And she was really your best bet if you had pancreatic cancer to get a reasonably early diagnosis, although that wouldn't be very early. But now we're bombarded with all sorts of imaging modalities, endoscopic studies, lab tests, surgical options to evaluate pancreatic